we have another speaker to come up, Christopher Nelson, who I'm just thrilled to introduce. He is one of our senior research assistants, and we've actually had two senior research assistants. Another one, Lindsay Lowe, who's not here, she is doing her third year of med school. Since we've been developing our program, we've had quite a few research assistants go through a lot of career changes. It's just been awesome. So when Christopher joined us at the time, he was working on his second master's degree, and so was Lindsay. And then he got into his PhD and she got into med school. And then we had about 10 researchers that were in nursing school at varying degrees, and all of them, except for one, have graduated. 2 of them have gone off to do a master's degree. One will be graduating in December, and the rest are working in community health or maternity health, and one is working right outreach down on in Vancouver. So we have somehow, in some way, I don't know, it's just been amazing how all of this has just been carried forward. So our team has grown and moved and continues to grow. So I'd like to introduce Christopher Nelson up, our senior research assistant with this particular Maverick project. He's been doing a bunch of other things as well. I said he's a PhD student with Zach at UBC, and his master's research was super interesting. He examined substance use and anxiety during the pandemic, and now his focus is on cannabis and psychedelics for both recreational and therapeutic use. He has helped lead all sorts of projects exploring stigma-related barriers to medical cannabis, and he is going to come up here and sort of walk you through what we've done with this pilot project. And he just brings a lot of rigor and compassion, and he's got this calming sense of humor as well that keeps us going. And I love his mantra. It's with the Grateful Dead seems to be the theme. I've heard it a few times with some of you. We will get by, we will survive. So here we go. And you're going to survive coming up here, right? You coming? Okay, good. Anyway, please help me welcome him.
Thank you, Florian, for that lovely introduction. And thank you both, Michael and Florian, for putting on this wonderful event for all us to learn about what's going on here at Kamloops and beyond. So I'm just going to jump right into it so we have plenty of time to hear from our lived experience panel. The Maverick Cannabis Project was one of the first recovery programs in Canada to formally integrate medically directed cannabis use into a structured residential setting. This is a significant departure from traditional recovery frameworks that typically followed strict abstinence-based models. Instead, the Maverick Supportive Recovery Program embraced a harm reduction and client-centered approach aiming to meet individuals where they are and offer supportive therapeutic tools, including medical cannabis as part of their recovery. For researchers, this presented a unique opportunity. Very little has been documented about what it looks like to integrate cannabis into formal recovery programming under medical supervision. So this project allowed us to do a couple of things. First, it allowed us to document what this kind of innovation looks like in practice, as well as understand how both clients and staff experience the program, and evaluate its feasibility, risks, and potential benefits in real-world conditions. Essentially, we wanted to know, can medical cannabis be part of a safe, effective recovery strategy, and what does it take to make that possible? Given the innovative nature of the Maverick program, or the Maverick program, this study was designed with several key aims in mind. First, we wanted to explore how clients experience medical cannabis use during their recovery. Not just whether it helped, but how it fit into their broader recovery process in daily life. Second, we needed to understand staff perspectives. Since staff play a central role in supporting recovery, their buy-in or discomfort can significantly shape program outcomes. Third, we were interested in how structured cannabis education contributed to both client safety and staff engagement. Did education change perceptions? Did it support more informed and responsible use? We also wanted to assess the feasibility and acceptability of integrating medical cannabis into a formal residential program. Could this model work in a real-world clinical setting? And finally, we aim to identify both the benefits and the barriers from stigma and policy uncertainty to therapeutic value and improved engagement. These insights can help inform future implementation in similar settings. Overall, the study was not just about whether cannabis works, it was about understanding what happens when it's introduced thoughtfully into a recovery environment. This research was a collaborative effort between the University of British Columbia and Thompson Rivers University, reflecting a shared commitment to exploring cannabis use in recovery settings through rigorous community-engaged research. We designed the study as a mixed method naturalistic pilot, which means we collected both qualitative and quantitative data while observing the program as it unfolded in real time. The study included 21 participants in total, 14 clients and 7 staff members from the Maverick Supportive Recovery Program. Data collection occurred over the span of about 1 year, allowing us to track participant experiences and outcomes over time. Outcomes were evaluated using a combination of semi-structured interviews and validated assessment tools included the QDID-R and the BC-CAT. Both clients and staff perspectives participated in interviews at multiple intervals, and this repeated measures approach helped us understand both the initial reactions and how perspectives evolve over time. So this graph shows the timeline for data collection in the Maverick Cannabis study. Participants, both clients and staff, were engaged at 4 key time points. First, at the initial program entry stage, then again at 1 month into participation, followed by a 3-month check-in, and finally a 6-month follow-up. This longitudinal approach allowed us to observe how perspectives, cannabis use patterns, and engagement with the program evolved over time. It also helped us assess both immediate and more sustained outcomes related to medical cannabis use in a recovery setting. While not all participants completed every phase due to factors like early discharge or dropout, the timeline was key to capturing the depth and progression of lived experiences. Our evaluation focused on several core outcomes that reflect both individual experience and program level impact. First, we looked at treatment effectiveness, particularly in terms of symptom relief, things like sleep, mental health, and pain, and how cannabis was used in place of other substances. We also assessed the feasibility in integrating medical cannabis into a structured recovery setting, including how well it fit with the program and whether clients and staff could engage with it in a meaningful way. Acceptability was a major theme. How open clients and staff were to this model and what factors shaped their willingness to participate. And we explored general perception, how people felt about cannabis being used therapeutically in a recovery setting, especially in light of traditional abstinent-based expectations. On the method side, qualitative analysis involved thematic analysis of interviews with both clients and staff, and this helped us identify core themes and understand their lived experiences. We also captured emerging insights about stigma, staff discomfort, and the evolving role of harm reduction in clinical care. Many of the clients in our program reported a range of perceived benefits from using medical cannabis. The most frequently cited included pain relief, improved sleep, and enhanced mental health, all noted by 100% of the participants who were at the study at 3 months, who remained in the study at 3 months. Another key benefit was drug substitution and reduced cravings that was reported by 86% of clients. This suggested cannabis may play a role in helping clients move away from more harmful substances. In addition to these perceived benefits, 2 emergent themes came up in the data. One was the use of cannabis as a substitute for prescription medication, and the other was stigma, identified as a barrier that limits access to cannabis treatment options. Importantly, all participants described cannabis as either very helpful or extremely helpful for their recovery journey, and again, 86% reported a noticeable reduction in cravings. Clients also shared that cannabis helped them stay on track with their treatment plans, manage withdrawal symptoms more effectively, and remain engaged in the rehabilitation program. To help illustrate these findings, I'd like to share a few direct quotes from our clients. These comments highlighted the deeply personal and often transformative ways in which cannabis has supported their recovery. As you'll hear, the benefits span physical, emotional, and psychological domains. One participant shared, "It helps with my mood overall, and it helps me with maintaining my energy, with my sleep, my anxiety, and my depression." Another noted, "The inflammation is down. I love that about cannabis. It doesn't mask the pain, so you don't damage it more." Participants also described improvements in sleep, as reflected in the statement, "I sleep like a baby, and if I'm a little bit tired, I just lay down and think of peaceful things, and I have a nap. I've never been able to do that." For others, cannabis supported substance use recovery. Cannabis, in quote, "Cannabis has significantly reduced the chance of me relapsing. If I would get a craving, I would smoke a joint and I'd feel a lot better." As well as, "When I use cannabis, I don't take opioids. I wean myself off of them and completely substituted it with cannabis." As we explored staff perspectives, we found a wide range of views reflecting their diverse therapeutic backgrounds and philosophies around recovery. Some staff recognized medical cannabis as a valuable tool. They noted that it helped clients manage symptoms like pain, anxiety, low mood, and sleep disturbances, and it even enhanced engagement and rehabilitation. On the other hand, some were more cautious. They voiced concerns about the potential for relapse and felt that cannabis use might conflict with traditional abstinence-based recovery models. Across the board, many staff expressed a strong need for more education. They wanted clinical guidance and opportunities to participate in shaping the cannabis program so they could better support their clients. Finally, stigma came up repeatedly. Both personal beliefs and broader cultural attitudes were seen as barriers, not just to staff acceptance, but also to open, supportive conversations with clients. In summary, our findings point to several important takeaways. First, medical cannabis may offer a promising harm reduction strategy, particularly in helping some individuals reduce or replace their use of more harmful substances like opioids or alcohol. Second, we found that integrating medical cannabis into an existing recovery program was not only feasible, but also well received by many clients. This highlights the potential for cannabis to serve as part of a more personalized and responsive approach to treatment. At the same time, we saw that stigma, especially among staff, remains a key barrier. This underscores the need for ongoing education, training, and open dialogue to support thoughtful implementation and address concerns. Ultimately, the success of this pilot study points to the potential for wider application in similar recovery settings, but further research is essential to replicate our findings, expand the program responsibly, and continue addressing stigma within recovery frameworks. Again, this is an evolving area of research, and we're just beginning to understand the full range of therapeutic possibilities and the questions they raise. Thank you very much, and you can contact me here.
You did it. Thank you so much, Christopher. We've gone through a lot with our small pilot study, but it isn't small. There's so much more to do now. We've just uncovered so many more questions, and I'm really excited about where we're going with it. So thank you.